Hello, my name is Kayla Morris, and today I'm going to be talking about endometriosis and whether it's best to excise or ablate the tissues, which is a systematic review. To start with, endometriosis is when endometrial tissue exists outside of the uterus. In simple terms, endometrial tissue is the lining of the uterus, which is what sheds during menstruation. Upwards of 10% of all women and 50% of fertility challenged women have endometriosis. In addition to this, over 70% of female chronic pelvic pain symptoms are caused by endometriosis. So as you can see, this affects a lot of women. Symptomatic endometriosis can present as dysmenorrhea, which are menstrual cramps, non-cyclic pelvic pain, dyspareunia, which is painful sexual intercourse, cycle-linked dysesthesia, which are symptoms similar to IBS, and dysuria, which is painful urination. Chronic pelvic pain, defined as pain for 6 or more months that is severe enough to cause functional disability or lead to medical care, is the primary symptom of endometriosis. Non-symptomatic endometriosis presents itself in fertility issues generally, and women find out that they have endometriosis when they struggle to get pregnant and their physician suggests doing an exploratory laparoscopic surgery where they find endometriosis. The cause of endometriosis is unknown. However, some risk factors have been identified. A first-degree relative with endometriosis correlates with a 3 to 9-fold increase of developing endometriosis. Additional risk factors include early onset of menarche and extended menstrual cycles. Treatments include hormonal suppression, pain relievers, and surgery, with surgery being the only confirmed diagnostic tool. Endometriosis is a chronic disease requiring lifelong management, and estimated yearly economic impacts exceed $20 billion in the United States annually. 2 surgical approaches are available as treatment for endometriosis: excision and ablation. In cases of deep infiltrating endometriosis, which is where the endometrial lesions are deep inside of the pelvic sidewall, surgical excision is required to completely treat the disease. In milder cases of endometriosis, ablation therapy is simpler and quicker, although it is often considered less effective. Excision cuts out 100% of the disease, while ablation cauterizes the surface of endometrial lesions, still leaving behind about 90% of the disease. The goal of this research project was to review whether surgical excision or ablation have better outcomes with regards to reducing pain. This information is helpful to physicians and patients when determining proper treatment of endometriosis. So in figure 1, it's just a visual representation of ablation and excision techniques. So ablation is the flamethrower, and it just burns the flower, but it leaves behind the root, which is about 90% of the disease, and the disease will return if it's not completely removed. Excision is like a trowel, and it completely removes the flower and the roots. And with this type of procedure, 100% of the disease is removed, so it is less likely to return. Methods for this research include information that was gathered in September 2019 via PubMed, CINAHL, and JMIG. JMIG is the Journal of Minimally Invasive Gynecology. Advanced searches were used using keywords such as endometriosis, excision, ablation, fulguration, pain, laparoscopy, and surgery. 45 articles were found and narrowed down to 8 relevant papers after duplications, inadequate study types, and foreign languages were removed. These studies were a mix of 1 retrospective study, 6 prospective studies, 2 cohort studies, 1 randomized double-blind study, 1 controlled trial, and 1 randomized observational study. Figure 2 shows us a surgical photo of endometriosis. So we are looking at the fundus of the uterus, which is the top of the uterus, and both fallopian tubes are visible on the side, as well as the ovaries, which are covered in endometriosis. So endometriosis is outlined by the black hashed circles, and this just shows what endometriosis can look like. However, it is not a complete photo of endometriosis, as endometriosis can present upwards of 11 different ways. So endometriosis can also be found on reproductive organs, as well as the bowel, pelvic sidewalls, and even places like the appendix, the spleen, the lungs, and even the brain. So with the results, 7 out of 8 studies reviewed showed a significant reduction of pain and superior outcomes with surgical excision compared to ablation. The single outlier study had limitations, including a small sample size and no histological evidence to confirm endometriosis. This is important because while the only way to visually diagnose endometriosis is with surgery, the only way to truly diagnose it is with a biopsied sample sent to a pathologist to confirm that it was in fact endometriosis and endometrial tissues. And with ablation, there is no way to confirm this, as ablation burns the surface level and no biopsy is sent. So 2 of the studies done directly compared excision with ablation. One study found that laparoscopic excision patients on average had less abdominal pain 5 years post-surgery than ablation patients, and this was statistically significant at a p-value of 0.03. The other study showed similar results with a greater reduction of pain in the excision group compared to the ablation group, and theirs was significant at a p-level of less than 0.0001. The remaining studies looked at the effectiveness of surgical excision alone. And then a few studies also looked at the effectiveness of ablation. All studies showed significant pain reduction following excision. The findings of the systematic review suggest that laparoscopic excision is the most effective treatment for symptomatic endometriosis. These findings are consistently supported by 7 out of 8 studies reviewed. These results are supported by an earlier review published in 2017. In the studies I reviewed, excisional surgery had a higher reduction in pain scale points, longer pain-free duration, and the most significant outcomes regarding pain reduction compared to ablation. Strengths of this literature review include multiple types of studies in multiple settings. This variability reduces the likelihood of bias occurring. The primary limitation of this review related to the lack of endometriosis studies, restricting the ability to directly compare excision to ablation on a large scale. Most studies incorporated small sample sizes, few studies were on the effectiveness of ablation alone, and less directly compared ablation and excision. Last, ablation studies did not include pathological diagnosis of endometriosis tissue due to the tissue damage that results from the process of ablation, which is what I was discussing before. With the tissue being burnt, there is no way to get a pathological diagnosis, and so there's no way to confirm that it was actually, in fact, endometriosis and not scar tissue or inflamed tissue or just unhealthy tissue. Excision is considered the preferred treatment of endometriosis care and even considered the gold standard. Results suggest that complete surgical excision of endometriosis is the most effective form of treatment. And when endometriosis is properly excised, endometriosis is less likely to recur, fertility is preserved, and symptoms are reduced and frequently even eliminated. Future research in this field should directly compare ablation and excision of histologically confirmed endometriosis, and this is possible by biopsying the tissue before ablating it. So if you just biopsied a small part and then perform the rest of ablation, it would be able to be histologically confirmed. I would like to personally thank the Carroll College Health Science Department as well as Gerald Schaefer for his continued support in my education and career goals. Thank you.